Traceforward Media, this is Healthcare Musings. I'm your host, Dr. Hassaballa. Welcome to Healthcare Musings, everybody. Happy to have you with me. Continuing on the mini-series about heeding the voice of Voltaire in the ICU. Remember, Voltaire is popularly associated with the term not letting the perfect be the enemy of the good. The French phrase is le mieux est l'ennemi du bien. The better is the enemy of the good. And when I think about that phrase, a lot of times end-of-life care comes up in my mind. And when it comes to end-of-life care, the perfect is truly the enemy of the good, right? If you think about it, someone comes in with critical illness. The perfect, quote unquote, is to do everything you can to treat that critical illness, right? Do every invasive procedure, every kind of treatment, everything you can to try to conquer the critical illness. Now, sometimes people are going to die no matter what we do. And most of the time, thankfully, people live and survive, sometimes despite what we do. That's the perfect, right? Every single time. That frequently is the enemy of the good in the ICU. Sometimes, just because we can do something doesn't mean we should do it. And that's where goals of care comes in. It is so important, let me say even critical, with the pun being intended, that the goals of care of the patient is outlined and communicated right from the get-go, right? What's very frustrating is if the patient's in distress, right, and an extremist, and then you turn to the family who's horrified and you say, "Do you want me to do everything?" I mean, come on, that's the wrong time to talk about goals of care, and then asking the question, "Do you want me to do everything?" is the exactly wrong, worst question. Or do you want to be a full code? That's the worst question you could ask. Ideally, and it doesn't happen. And ideally, the goals of care should be done way before in the primary care physician's office or in the outpatient setting, and then clearly communicated that these are the red lines that I have. These are the goals of care that I have. And it's not. Okay. So a lot of times it is. And a lot of times when people come into the ICU, I need to know how far do you want me to go? What are your red lines? It's not ideal. I hate it when the patient's about to die and then we turn to the family and say, "Do you want me to do everything?" I mean, I can't stand that. That's not the ideal situation. The problem is it's not done a lot. And so we're forced to do it that way. Okay. But doing everything sometimes is the enemy of the good, right? And so you have to think about how far do you want me to go to treat this critical illness? What treatments can I do, or what treatments will I do that will cross your red lines? And that's why the question, "Do you want me to do everything?" is the worst way to ask it. I hate when they ask it that way. What I say, not saying that mine's perfect, but what I say is, okay, if you saw yourself, if you stood where I'm standing and you saw yourself hooked up to machines, what would you say? Or, "Yes, I want everything done." They told me, yep, they said they want everything done. My retort is, "Do you want to live your last days on a machine?" Because that's what the perfect is. The perfect is to, put someone on invasive mechanical ventilation, all these tubes, central line, arterial line, dialysis, CRRT, ECMO, all these things. That's the perfect. Okay. Is that what you want? Do you want to live your last days on a machine? If this critical illness ultimately is fatal, do you want to live your last days on a machine, having us pound on your chest and shock your heart? That's the question to ask. And I tell you, most of the time when you frame it that way, the patient says, no, I don't want to live my last days on a machine. Me personally, I don't want to live my last days on a machine. There's no way. I don't want to live being pounded on I don't want to be fed through a tube if I can't help it. No, I don't want it. Those are not my goals. I don't want to even have nasal surgery, because if there's a 1% chance that I can't taste food afterwards, I'd rather be dead. I'd rather be dead, and I have a deviated septum. That's my goal of care, right? So when you frame it that way, and the same thing with the family. See, when you ask the family, do you want everything done? Of course they're going to say that. They're their loved one. They don't want them to die. And then you put the burden of guilt on top of them, and you just say, well, it's your decision, if they live or die. That's not the question you ask the family. You ask the family, if mom, dad, grandma, grandpa, brother, sister, whatever, if they stood where I'm standing and they saw themselves in the bed hooked up to machines, what would they say? And a lot of times the family, it's painful. And the family says, they shake their head and say that they would not want this. The way you frame it that way, it takes the burden of guilt off the family. They're just speaking for their loved one. They're not the ones pulling, quote unquote, pulling the plug or making that life and death decision. They're not. The patient is. Okay? And so the perfect being the enemy of the good, Voltaire is telling us that just because we can do something doesn't mean we should do it. It's super important that we know right away what the goals of care are. And I see it a lot, and we just say, I just want to know about your code status and what your full code. If it's not outlined, I think it is important. It's not the perfect time, but the problem is we don't live in an ideal world. Ideally, everybody has their goals of care all outlined, and they come in, and there's no question. We don't even have to have goals of care conversations, right? Advanced care planning in the ideal world, there will never be advanced care planning in the ICU. We don't live in an ideal world. I know that. We don't live in an ideal world. And so a lot of times we are having goals of care conversations. Sometimes even when the patient is in extremis or in distress. I hate it when it does, but we don't live in an ideal world. At the same time, asking, do you want me to do everything, connotes indifference on the part of the clinician as to the patient's care. Like, why are you asking me that? Do you not want to save your patient's life? Why are you asking, do you want me to do everything? No. What you're asking is, does the patient want to live their last days on a machine? What are the red lines? What treatments are consistent with their values and preferences? That's the question we're asking. And that's what we need to ascertain right away. Because truly, in the ICU, when it comes to all the marvelous medicine that we can do, the perfect is the enemy of the good. And so let me mimic Voltaire here and say, parce que je peux faire quelque chose, il ne suit pas que je devrais le faire. Meaning, just because I can do something doesn't mean I should do it. And so again, this is another instance of heeding the voice of Voltaire in the ICU. Thanks so much, everybody, for your time and attention, and I'll see you next time on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.